Welcome everyone to QE1 Exam Preparation Session 2023, organized by the Young Physician Committee of Alberta, EPNA chapter. I am Dr. Wasia Samreen. I am an IMG and I did my LMCC certification, and now I'm pursuing my career through PRA route. Today I will be moderating your session. So QE1, as you all know, QE1 is the first licensing exam that all IMGs have to take when they come to Canada. Before we begin our session, I would like to invite the president of APNA Alberta chapter, Dr. Saad Yassin, will give you a little introduction about APNA. Dr. Saad Yassin graduated from Karachi, Pakistan, and completed his family medicine training from England in 2005. He has been practicing as a family physician over 17 years, including in Calgary for the past 10 years. Dr. Saad Yassin is passionate about teaching medical students and currently holding a faculty position as a clinical assistant professor at Cummings School of Medicine, University of Calgary. He was a recipient of Teaching Award from the University of Calgary. He is also a member of Virtual Education Committee and Membership Advisory Committee of Alberta College of Family Physician. Dr. Saad Yassin is a founding member of Alberta chapter of APNA and has served as an intern 3 years before taking the role as the first elected president of APNA Alberta chapter in 2022. He is also a member of various other charitable organizations in Calgary and spends hundreds of hours of volunteer work every year. Over to you, Dr. Saad.
Thank you, Dr. Samreen, for your kind introduction. APNA Alberta chapter is the Association of Physicians of Pakistani Descent of North America. Welcome you all, the attendees, to this very important webinar. APNA is the third largest medical association in the United States. APNA was founded in 1974 and registered in 1976. It is dedicated to supporting scientific development and education in medicine and delivering better healthcare regardless of race, creed, or gender. APNA is representing more than 20,000 physicians and healthcare professionals of Pakistani descent in the United States and Canada. It has 38 chapters across North America and has 16 alumni. I would like to thank APNA Alberta chapter Young Physician Committee to organize this very informative and important webinar for all the IMGs who are interested about the health system in Canada from the examination point of view and eventually want to work here as a physician. So good luck to you all. I hope that this session is very informative to you.
Thank you so much, Dr. Saad, for giving us a brief introduction of APNA and Alberta chapter. We have with us today 3 of our panelists who will talk about different strategies for the QE1 exam. You are all welcome to write your questions down in the chat box and we will answer them at the end of the session. So without any further delay, I would like to invite our first panelist, Dr. Zarka Qureshi. Dr. Zarka has worked as a clinical assistant for medical and radiation oncology for 4 years, and she did her residency training from University of Calgary and has been working as a family physician for the past 3 years. She will talk about the CanMed roles and objectives, which are I would say, very important at each and every steps when you are pursuing your career in Canada as a medical physician. So over to you, Dr. Zarka.
Hi, thank you, Dr. Samreen. Hi, everyone. My name is Zarka, and I am a graduate from King Edward Medical College. As an IMG myself, I know getting into the residency and getting into the healthcare system is sometimes very stressful, but with your hard work and persistence, inshallah, you all can do that. Today, in our qualifying 1 exam preparation session, I'll be talking about the objectives of qualifying 1 exams, and they are CanMed rules also. So I'll open my, so give me a second. So the CanMed rules or the are actually the qualities and attributes that one physician should have in the Canadian healthcare systems. So there are 7 CanMed rules, and the medical expert is being the core, but the other important are communicator, professional scholar, especially for your qualifying one exam. So you will be assessed in your qualifying one exam on those roles in the healthcare system. All these objectives are taken from the Medical Council of Canada qualifying exam website. So first, I will be talking about the role as a medical or the clinical expert. So as a clinical expert, they will be assessing you on your medical knowledge. And it has a very integrating role. And from the history and physical exam, your role will be to interpret and arrive at a reasonable diagnosis, suggest next investigation, or suggest the management plan. So let's first talk about on the how the tips to get into the reasonable diagnosis. So it's important then while you are reading the question stem that you differentiate between the important and unimportant information or unrelevant information. You have to differentiate. Also knowing about the most common medical condition, but also rare and life-threatening conditions. So one of the example is that if a patient comes with the swelling of one calf and this redness of the calf also, if there is any history of travel, if there is any history of history of cancer or on hormonal, so it will be a grave mistake if you will miss the diagnosis of DVT. So with the knowledge, I think you can come to a reasonable diagnosis. Also, it's important that you know about the common medication, their clinical applications, side effects, and interaction. Coming to the investigations, so when they will ask in the question about the investigations, it's important that we pay attention to what is the question. Is it next most common or diagnostic? So one of the example is if the question is regarding the cough with intermittent fever, so the most next common will be investigation will be chest X-ray, but diagnostic will be biopsy. Now it's when the management plan comes, it can be short-term and long-term. And also it's important that we differentiate between acute emergency situation or if it can be managed in the outpatient. Also when to refer for a consultant or a specialist. So next is the role of a physician as a professional. So so physicians have a very unique role in the society and the community. So their behavior, and their skills, their knowledge is all guided by the code of ethics, commitment, and accountability. So I'll be talking a little bit about the accountability. So when we say as a professional, accountability to yourself is about knowing your limitations and also how we can do the ongoing learning and improve our medical education. It's all about knowing the new guidelines. So it's about being a professional to keep yourself updated with the new guidelines. Then for patients and families, so there are few things that are important as an ethical point, like confidentiality, autonomy of the patient, taking care of the patient's safety. So I'll be talking a little bit about these, but Dr. Samina will be telling you more about those ethical parts. So confidentiality is it's important that we keep the confidentiality of the patient. That can help in the building the trust between the patient and the family, patient and the doctor. But also sometimes there is a limitation to that, such as if there are reportable diseases, if there is any harm to the life of the patient or life for the others. So then there can be a breach of confidentiality. Autonomy is also very important in the modern healthcare system. It's a patient-centered approach. So we should be respecting the wishes of the patient. And this can help to get into the shared decision-making when we will be planning will be doing the management planning. Also, it's important that a physician should demonstrate perfect behavior to ensure patient safety. And in case if any error happens, it's important that timely, honest, and full disclosure to the patient and the families. For societies, physician as a role of professional has a leadership role to improve healthcare. And when interacting with the other healthcare professional, it's important that we respect others' expertise and also assume the responsibility of our own actions. Also, there are some very complex medical issues like medical assistance in death, maternal fetal conflict, that we have to respect and understand those ethical issues. Another role is as a communicator and collaborator. So as communicator, a physician effectively facilitate the doctor-patient relationship. So when we are with the patients and family, having empathy, cultural sensitivity, and respect for diversity is important. And creating management plans based on their shared goals. So when we are talking about the other healthcare providers, the communication should be clear and timely manner. There is also communication with the third parties, such as insurance companies, government agencies, and definitely with the consent of the patient. As a communicator, sometimes there are challenging situations, such as breaking bad news, goals of care discussion. And here, the role of the communicator as a communicator is very important. For the breaking bad news, there's a spike protocol that we all should follow and we all should know. So a physician is a role as a scholar. So it is actually demonstrate a lifelong commitment to reflective learning. So education of personal education to, like I talked that before, that knowing the new guidelines, there are asthma guidelines, diabetes guidelines. So we have to keep ourselves updated on that. So that's another thing, to apply the principles of research and evidence-based medicines in our practice. So it's from exam perspective, if you should review sensitivity, specificity, and positive and negative predictive values for the investigations. And when we are talking about learning, facilitating learning to the others, to the trainees, and also educating patients. So one example to educate patient is when a patient comes with a knee pain and this is due to the osteoarthritis, we can help them understand what osteoarthritis is. It is a chronic, it has an inflammatory condition, and what steps we can take to help with that. So when you will educate the patient, that will help to make a shared decision making, and then that can also help in the compliance for that management. So another role is of a physician is as a manager. So physicians have a very integral role, and they are integral participants in the healthcare association about allocating resources. So these resources can be human resources, diagnostic, and therapeutic. So these should be allocated without discrimination and with an ethical and informed manner. So Choosing Wisely Canada is a campaign that encourages all of the physicians to choose the investigations or consults or referrals very wisely. So, and then as a manager, it's important that we manage our practice, like set priorities, manage time effectively, and also as work-life balance. So when I was talking about choosing wisely in the investigation, whenever we order any investigation, and in the question also, you should think about, is this investigation, what is the implication of that? Is this investigation is going to change the diagnosis? Is this investigation is helping the diagnosis, or is investigation will help, how this investigation will help in the management plan? So also as a manager, it's important that we play higher level participation in the healthcare system. There are advocacy groups, regulatory bodies like College of Physicians and Surgeons of Alberta. There are professional associations, and also knowing and recognizing the barriers to patient care. So this is the exam blueprint. We already talked about the role as a objectives or the rules of CanMed rules as an expert, communicator, and professional. So if you can look at that, okay, maybe it's not showing. So these are on two dimension of care and physician activity. So almost 80% of your assessment and marking will be on as a clinical expert, like assessment, diagnosis, and management. And 20 to 30% will be from the communication and professional behavior. So I'll just quickly go over a few of those things. So regarding, so there will be questions regarding health promotion and illness prevention. So in that comes sometimes like the screening tests. So screening tests for colon cancer, breast cancer, mammography, the FIT test for the colon cancer, and the PAP test for the cervical cancer. So we have to know about those screening guidelines. For health promotion, there is counseling, smoking cessation, lifestyle changes. Those counselings are important. If we see the acute care, I'm just giving an example of chest pain. Chest pain has a very vast differential. So when a patient comes, it's important that we differentiate between very life-threatening, like cardiac problem, pulmonary embolism, or sometimes in our clinic, we see most of the patients come with the chest pain that can be due to the costochondritis, gastroesophageal reflux. So it's important we differentiate that, and when to send them to emergency, or do we have to manage as an outpatient. In communication in the acute care is to discuss about the red flags and reassuring the patient if there is nothing concerning. In the chronic, there are many chronic medical conditions. One of them is diabetes, that is very common. And it's important to know the guidelines, how to diagnose, what are the criteria, and also according to the age, what are the criteria to control the diabetes, and management plan. And the communication is about educating the patients. So in diabetes, lifestyle modifications, lifestyle changes, and educating the patients regarding the complications and the importance of compliance with the medications and health and lifestyle is very important. Then there are also psychosocial aspects. So that can be financial, cultural, social risk factors. So there are like certain medical conditions are more prevalent in certain communities. So if we would know that, that's easier to help us to diagnose. So there are, so I think then Dr. Maria and Dr. Samina will be talking about the questions, and then you will realize most of them are coming from these CanMed rules. And thank you so much for listening, and best of luck for your exams.
Thank you very much, Dr. Zarka, for valuable information about CanMed rules. Just a reminder for everyone, if someone has any question, please write down your question in the chat box and we will answer them at the end of the session. Now, I would like to invite our second panelist, Dr. Maria Hussain. Dr. Maria has completed her internal medicine training from the University of Calgary in 2021. And now currently she is working in medical oncology as doing her residency in medical oncology from the University of Calgary. So she will talk about exam tips and sample questions. So go ahead, Dr. Maria, over to you.
Hi, everyone. I'm just going to share my screen here. Hey, is everyone able to see my screen? All right. So I'm going to be talking about exam day tips, some test taking tips, as well as sample question reviews. The purpose of the question review is not to cover everything there is to know, but like it's not for content, but more so to help you sort of when you're looking at a question, what are the important things that you need to see, things that you need to pick out, and we can work through some of the questions together today. I encourage you to look on the slides. You'll see little stars on some of the slides, and these are for me to point you towards high yield resources. You can take a picture or note it down, and you can go back and read these resources and guidelines. We will have, when we go through the question sections, we will have polls coming up for each of the questions. Again, I really encourage everybody to participate. It is a good self-testing, and it's not to tell you that, this is how you'll perform on the exam, but it's just a good reflection of your own skills and what things you may need to work on. Okay, so let's start with the exam day tips. So this is information that we know from the LMCC website, but I'll go over it here, that there's 210 MCQs that have to be finished in 4 hours. The LMCC recommends that you spend no more than 1 minute and 8 seconds on each question. I would recommend that you time yourself for even less, give yourself a minute per question, just so you can have some time at the end. There will be 3 to 5 answer options for MCQs. They've changed this in the past years that some questions will have 3. This is to reduce sort of that cognitive load on us when we're looking through answer options. No, there's no penalty. This is exclusive for the MCQ section, not for CDM. But here, there is no penalty for wrong answers. So answer every question to the best of your ability. If you are unsure about a question, I would say pick your first initial answer guess and move on. There's an option to flag the question as in the exam, so do that and then quickly just move on to the next one, and you can come back to your flagged questions. Don't sit and harp on a question, because minutes go by pretty fast when you're actually in the exam. And then try not to go back and change the answers that you were confident about that you had answered previously. So I would recommend that don't flag them, because it's habitual to just flag as many as we can so we can review them, but it's better to actually just, if you're confident about an answer it and move on. And usually our first guess is probably the best one, and the more you go through questions, when you come back to them, you want to change the answer. And then as you go through the questions with me today, we'll focus on what the question is asking. Like, is it asking for, what setting is it in? Is it in an emerged setting or an outpatient setting? What is it? Are they asking for the next best step? Are they asking for the most important step? Or they're asking for, what's the best way to diagnose, what's most sensitive? Or so that's the important key, that last part of the question where they mention those things. And in this exam, the LMCCs, all of them actually, is that the key is that they want you to be safe. So you want to pick can't miss things. So that's one thing. You want to pick things that you shouldn't miss on for a diagnosis, or things that you should absolutely order when you know a diagnosis. So that's the big thing, that you should pick can't miss management items, because as we go through, you'll see that technically all 5 of the answers could be correct, but you want to pick things that that you don't want to miss. So they may be factually correct, but may not be the answer they're looking for. Okay, so let's start going through the questions. Oops. Right. So I'll read the first question for you here, and then we'll pull up the poll. So a 65-year-old gentleman is being treated for an acute myocardial infarction. He originally came to the Emerge with substernal chest pain and diaphoresis. Given his risk factors of hypertension, diabetes, tobacco use, and family history, he is considered high risk. An ECG in the Emerge reveals a left bundle branch pattern, and cardiac enzymes are elevated slightly. After a focused evaluation in the Emerge, the patient receives intravenous thrombolytics. Although his bundle branch pattern never resolves, the patient is chest pain-free and hemodynamically stable after thrombolysis. 2 days later, the patient reports episodes of recurrent chest discomfort and shortness of breath overnight. In evaluating for potential MI reinfarction, which of the following is the most appropriate diagnostic test? So we'll have the poll pull up, and if you guys can pick your best answer. Okay, if you can bring up the answers. Okay, so a lot of variation here. Majority of the people are saying TROP-I levels, and then sort of a mix of the other answers. So let's go through this problem together. Okay, so the correct answer here is A, creatinine kinase. So let's look at the question. This question requires knowledge of different cardiac markers and their half-lives. So that's what they're getting at here. So the correct answer is A, creatinine kinase. The reason being is that when there is a reinfarction in a hospitalized patient, creatinine kinase is one of the, specifically the CKMB is one of the cardiac markers that's elevated early. So it's up as early as 3 hours. It has a duration of just 1 to 2 days. So it will have gone down within that 48-hour period, and it peaks pretty quickly. So within 18 to 24 hours. So it's easier to track in a hospitalized patient. So a sudden increase in CK in this patient will indicate to you that there's new myocardial infarction. The other answer choices, so dynamic EKG changes, this is where I've highlighted in red that his bundle branch pattern never resolves. So if a baseline EKG is not normal to begin with, it will be very hard for you to reevaluate a infarction in that setting. So unless the baseline EKG post the MI had gone completely normal, then it would have been a helpful thing. But in this case, it would not be helpful. So those are the things you should pick out in the question as you're reading through. The next option was C, lactate dehydrogenase. We all know that lactate dehydrogenase is extremely non-specific and non-sensitive. So it can be elevated if you have muscle injury, it can be elevated for a lot of days. And once elevated, it stays elevated for a long time. So 6 to 8 days. So again, this would not be helpful in this case. The myoglobin levels, although they're a very good marker for an acute injury to the muscle. They're not sensitive for this. So they're not specific for this. So myoglobin can be elevated in other things. And in a hospitalized patient, they will have some sort of muscle degradation. So it will again not be helpful because it can be elevated for multiple reasons. And then the last one, the troponin. Majority of you picked the troponin, and it's because it's our natural instinct to say troponin is related to the myocardial infarction. But as you know, troponin increases 3 to 12 hours after an MI, but it stays elevated for 10 days. So even unless you're really tracking the troponin every single day, and then you saw it drop and then rise, then it may give you a hint, but again, not as good as a CK for this. Okay, let's move on to the next question. Here's question number 2. So we have a 73-year-old gentleman that comes to the emerge complaining of abdominal pain. He describes a dull, aching, constant pain in his mid-umbilical region. The pain has persisted over the past few days with increasing intensity, and it is not relieved by changes in position or eating. The patient has a medical history significant for hypertension and coronary artery disease. He had an MI 3 years ago. The man has moderate peripheral vascular disease with a prior femoral popliteal bypass graft on the left. On physical exam, his blood pressure is 180 over 100 and his pulse is 86. He has a loud S4, a pulsatile midline abdominal mass, and venous stasis changes bilaterally on his lower extremities. Which of the following is the most appropriate diagnostic test at this time? So let's pull up the poll here and we can see the answer options on there. Okay, let's move on to the answer. All right, so a mixed bag between abdominal ultrasound and CT abdomen. Nobody picked CT spine and spinal MRI, which is excellent. And then a few people picked LS spine films. So we'll talk about all of the answer options. So between abdominal ultrasound and CT abdomen, the room is somewhat split. Okay, so the correct answer here is abdominal ultrasound, so B. As I go through this question, I pick out first, it's a two-step question, right? So it's requiring you to understand what the diagnosis is and then understand what sort of comment on which test you think is most appropriate. So that's how they worded it. And you want a most appropriate diagnostic test, right? So you want a test that can appropriately answer your question. So a pulsatile abdominal mass in a patient with vascular, like a vasculopath, as we call them. They have a history of vascular disease, hypertension, myocardial infarction. So it's an abdominal aortic aneurysm. So that's what your diagnosis is. So as you're reading through the question, your mind should have distilled by the end that this is my diagnosis, and now I need the test for it. The reason the correct answer is B, ultrasound, is that it's the most cost-effective and timely screening test for suspected abdominal aortic aneurysm. When a patient comes to the emergency department or in the hospital, the most timely thing you can order is an ultrasound. It can be done quickly. And secondly, it can very well answer your question for an abdominal aortic aneurysm. Half the room picked D, CT of the abdomen. I understand why you have picked that answer because, like I said, some answer options will be factually correct. So that is factually correct. You can get an answer in the CT scan as well, but it is twice as expensive as an ultrasound, and you're exposing the patient to a whole lot of radiation for really no and cost and radiation to get the same answer that you can get from an ultrasound. So this is an example of the kind of things they'll get into in this exam. The other answer choices, nobody picked CT of the spine and spinal MRI, which is great because those are done for evaluating spinal pathology. So they are not going to answer the question of an abdominal aortic aneurysm. They will answer the questions of whether you have an abscess in the disc or cord compression or disc pathology. And then I think few people picked lumbosacral spine films. Again, that's to answer the question whether there's anything wrong with the bone. The vertebral bone, so that can answer that question, but won't tell you about any. All right, let's go to the next question. Question number 3. We have a previously healthy 22-year-old female who comes to her physician complaining of a cough with sputum production for the past 3 days. That cough has been keeping her up at night and it is affecting her school performance. She has no prior history of respiratory disease. Her temperature is 37, blood pressure is 130/80, pulse is 70, and rests are 18. Physical exam is unremarkable. Which of the following is the most appropriate next step in management? So we'll pull up our poll here with the answer options. All right, it's a short question, so we'll put up the answers now. Okay, so again, mixed bag here. So 55% say we should perform a chest x-ray, some sputum culture, 24% say no therapy. So mixed answers, majority wants to do a chest x-ray, and then the next sort of group of people said send home with no therapy. All right, so the correct answer here is E, send home with no therapy. And the reason being, this is again coming to the same concepts that, what's most cost effective, best for the patient, no exposure to radiation. In a patient who's 22, she's healthy, just 3 days of cough and sputum, right? And then if you look at her vitals real quick, like she has no underlying respiratory disease, so nothing you're overly worried about that could put her at an increased risk for a bad infection. No afebrile, no temperature, blood pressure is normal, respiratory okay, physical exams are unremarkable. She's really fine. She's most of what we see, like what patients go to family docs for, right? 3 days and you're like, I still have this cough, and coughs can take a long time to go away. So this is the diagnosis here, acute bronchitis, most likely viral in origin. So the best answer here is that she doesn't need any therapy, right? She doesn't need antibiotics. Chest x-ray is to answer a question if you're really wondering about pneumonia, but in a healthy 22-year-old, with no other red flags or things to make you worried. Her oxygen saturation is normal and your lung exam was normal. So there's no reason to do a chest x-ray and expose her to radiation, whatever little radiation there is, but there is radiation, and it's, it still costs something, even if it's little, and it's still, and there's no question you're asking. You don't want to know about a pneumonia, even pneumonia as a clinical diagnosis, actually. So that's not adding anything. Sputum cultures, we We don't routinely do sputum cultures if somebody's admitted to hospital and is elderly or has a chronic disease or alcoholic or something that puts them in an increased risk for abnormal, like weird bugs or weird bacterial infections. Then you would do a sputum culture, but in this healthy person, there is no need. And antibiotic would definitely be not choosing wisely because it's overkill. This is likely viral and it will go away on its own. And then when you're reading this question, think already that they're in the family medicine setting because they've gone to their physician, not in the emerge, so not that sick. So that should already have you thinking that, we likely, she's okay. And then as you look through the vitals, you're like, she's fine. She doesn't need anything. Okay, next question. We'll go to question number 4. A 19-year-old woman comes to the emergency department after a syncopal event. While working in the garden, she accidentally disturbed a wasp's nest and was stung on her right hand. She has never been stung before and does not know if she needs treatment. The woman tried to rest at home but felt extremely ill and called for an ambulance. She currently complains of dizziness and has some swelling in both of her hands and feet. Vital signs are temperature 37.8, so that's 100, blood pressure 83/40, pulse 130, and rest 22. Oxygen saturation is 97% on room air. Lung auscultation reveals a diffuse mild wheeze. Which of the following is the first priority in caring for this patient? Let's have the answer options pull up. Okay, we'll pull up the answer options now. Okay, so majority say administer epi. Few people said give a bolus, and few said IV steroids. And yeah, nobody thought we need to intubate this patient, which is excellent. Okay, so let's go through the answer. The answer is correct. So majority was right. Administer epinephrine. Oops, here we go. So yeah, as we go through this question, again, you have to recognize this person is sick and needs treatment right away, right? So alarm bells going off, you're saying she's dizzy, she has swelling, she has temperature, she is low blood pressure. So all of this is to say that these things sort of fit the definition. So I would encourage you to read the definition of what qualifies as an anaphylactic shock. So this I would say is an anaphylaxis, anaphylactic shock. The reason I call it shock is the blood pressure is low. So this meets the definition of that. And the question is asking us, what is the first priority in caring for this patient? So again, factually, you could be doing multiple things at one time, but what needs to go into the patient first to stop the process, underlying process? So that's what they want to get at, right? Like your instinct does want you to do B as well, like bolus patient with 500 cc's of normal saline, which will maybe bring the blood pressure up intermittently, and you might need to do that regardless of the epinephrine at some point, but it's not going to treat the underlying problem. So that's recognizing what type of shock it is. So that's what they're trying to test here. So if it was a hypovolemic shock or a septic shock, then a bolus will probably be more helpful. But here you need to stop the underlying process. So epinephrine should be the first thing going in. C, correctly, everybody, nobody thought we need to intubate this patient. They're saturating well, she's dizzy, but she's awake. So she's protecting her airway and she's saturating okay. So there's no reason to intubate. D, diphenhydramine and cimetidine, you will probably end up giving this patient that because for the underlying sort of histamine reaction that they're having, but it will take a long time to work. So it's not a key thing that you need to do as a first priority in an emergency situation. IV steroids, again, it will prevent that late phase reaction, that IgE-mediated histamine release. However, again, it's a delayed effect. So we will give the steroids actually in an expedited manner. So right after all of this, you will actually get them like intravenous steroids into the patient, but it's just not the first thing that you will do. Okay. Oops. All right, next question. Okay. So We have a 60-year-old female who presents to your office for severe abdominal pain. She reports that she developed vague left lower quadrant abdominal pain yesterday. This morning, she woke up from her sleep with severe diffuse abdominal pain, anorexia, and vomiting. On exam, she's lying very still, temperature is 38.4, pulse 106, rest 16, blood pressure 100/62. She has dry mucous membranes, her abdomen has diminished vowel sounds, and is rigid with involuntary guarding and rebound tenderness, greatest in the left lower quadrant. On pelvic exam, she's exquisitely tender on the left with a palpable mass. There are no masses on rectal exam, and her stool is negative for occult blood. Labs, negative pregnancy test, WBCs are elevated at 25, hematocrit 32%, platelets 450, sodium 142, potassium 3.2, BUN 24, and creatinine 1. Abdominal X-ray demonstrates free air under the diaphragm. Based on the information available, the most likely diagnosis in this patient is, so we'll pull up the answer options. Okay, let's look at the answers. All right, so majority again has said diverticulitis. A few people scattered of the other diagnoses. The second sort of most popular was ovarian torsion. So let's look at the answer here. So yes, the correct answer is C, diverticulitis. Oops, okay. So yeah, this is a very long stem, but not atypical for the LMCC. So we have to get in the habit of just reading long stems and distilling the information in the first go as you read. It takes a lot of time to go back and read everything. So as you're reading, just pick out the key points. So location of the pain, right? Left lower quadrant abdominal pain. It's diffuse. She's lying very still. So all this tells you that the pain started in the left lower quadrant and now the patient is peritonitic. So all of these words that I've highlighted are telling you the exact same thing, that the patient is peritonitic. So she is lying very still, rigid with involuntary guarding, rebound tenderness, a little bit of hypotension, a little bit, she's febrile. So she obviously has an underlying infectious process, possibly, or inflammatory process, and then she's peritonitic. And then the labs, I would say, yes, get in the habit. They, well, I can't recall, but we'll confirm like if the reference sheet is there, but you should, there's not enough time. If there is even a reference, you should get in the habit of knowing the normals for these big basic things like the hemoglobin, WBCs, platelets, and then sodium, potassium, creatinine, just the normal labs for that. So you can instantly see what's elevated, what's not. And then abdominal X-ray demonstrates free air under the diaphragm. So this is important, right? This tells you that there is a hollow viscus that has perforated. So that's going to sort of guide you between sort of some of the answer options. So the correct answer is C, diverticulitis, because the pain is on the left side. There is air under the diaphragm. So the colon is a viscus with air, right? So there's air under the diaphragm because there's likely a perforation of that hollow viscus. The other answer is pelvic inflammatory disease. It's tempting because, you know, they've said she has a left like palpable mass. She's tender on pelvic exam, but this is a distractor. It's unlikely. She's 60 years old, and the clinical presentation, the clinical exam is not specific for pelvic inflammatory disease, and they haven't given you any other history to suggest PID. For B, appendicitis, again, the location, the pain was on the left side, started on the left side. So appendix can turn into this picture, but the pain would have started at the McBurney's point on the right side, not on the left side. And then ovarian torsion, again, the mass on the pelvic exam may throw you off to say that, but she's postmenopausal. Unless there's a malignancy, it's unlikely. And then the pain is different in nature. This pain is, it was vague, continuous pain. The pain of torsions is mostly colicky rather than constant. And then you wouldn't see peritoneal signs and you wouldn't see free air under the diaphragm. So, so this question is a bit tricky, but I think most of you got at the diagnosis. Okay, next. All right, so the shorter stem finally. So a 29-year-old woman presents with a 5-day history of arthralgias and a purpuric eruption on the lower legs. The most appropriate initial management is, I'll pull up the answer options. Okay, and let's look at the answer because the question is short. Okay, really a lot of disparity here. Majority said urinalysis, oral steroids, and sort of mixed bag of compression, reassurance, topical steroids. Okay, so let's look at the answer here. So the correct answer is D, urinalysis. Okay, there we go. So they're asking for most appropriate initial management. So first things first here is, what is the diagnosis, right? So you have to be able to know the diagnosis to know the next step. So this is getting at HSP, or henoch-Schwann purpura, which is a acute systemic immune complex mediated leukocytoplastic vasculitis. So it's a vasculitis that gives you a skin rash. It's characterized by a triad mostly of palpable purpura. So you'll have purpura in the legs. They haven't given more details here, but they could tell you that platelets are normal because that's a characteristic of it. Abdominal pain, and then arthritis. So mostly it starts with an upper respiratory illness. So if the question has more details, you'll get more of a hint. But in a young female with arthralgias and that rash, that's what you should be thinking about. So again, the answer options here are not all, but some are factually correct. So let's go through them. So D, urinalysis. The reason being this is that most of these patients will have arthritis. They will have abdominal pain, like I said, and then 40 to 50% will develop renal disease. So that's what you need to rule out here, because 94% of these people are of children, and nearly 85% of adults will spontaneously, this will resolve on its own. You will not need to treat it, but you will need to recognize those that will have severe renal involvement. And the way to do that is to do a urinalysis and look for what we call active sediment, right? So are there dysmorphic RBCs? Is there extra protein in the urine? So that's the purpose of doing the urinalysis, to recognize those patients who may then be the ones who need this B, oral corticosteroids, or so that would be the treatment, right? You may need to give them immunosuppressants, including steroids. So steroids could have been a correct answer, but we don't know if there's renal involvement here. And if there isn't, and the patient is, then the answer would be E, reassurance, and it will self-resolve. So it's tricky because B could be a potential answer, E could be a potential answer, but first you need to do the urinalysis, because it says initial management, and management doesn't mean treatment, right? Management doesn't mean, I had to get in the habit of realizing that management is everything from when you see the patient to making the diagnosis, the diagnostic tests, and the treatment. So urinalysis falls well under the management category. So yeah, we can then do reassurance if the urinalysis is normal, or do steroids if it's not. Compression of the lower legs will not help with the purpuric eruption here, right? This is the underlying vasculitic process, so there's nothing that requires compression of the lower legs. And then topical steroids, again, have no role. The rash is not a topical rash. It is more of an underlying small vessels that have burst. So the topical steroids will not do anything in this case. Okay, next question, question number 7. A 70-year-old man is seen in your office for assessment 1 week after experiencing a brief episode of left arm and left facial weakness. Blood pressure in your office is 140/80. A CT scan shows no evidence of hemorrhage or space-occupying lesion. An EKG has normal sinus rhythm. Which of the following is the most important investigation to order at this time? I'll pull up the poll. Okay, let's look at the answers. Okay, so mixed bag, but again, majority say carotid artery ultrasound, and then MRI is sort of the next popular option. And if some have said ECG, okay. So let's go to the answer. So the correct answer is E, a carotid artery ultrasound. So this it says most important investigation. This is a very tough question, I would say, because they could all potentially are correct answers again, but it's here to recognize what's already been done and what's going to be most helpful to this patient. I have started a study resource here, which is a stroke best practices guidelines. So they have, these are quite extensive. I would not recommend that you have to remember everything, but just have a read through so that you know what do we order in what setting, and what's the timelines of strokes and what to order in which setting and emerge, and in the family medicine clinic. So it's a good resource, especially when you're looking for answers for questions. So the Canadian Stroke Best Practice Guideline calls for non-contrast CT of the head to be done immediately for all patients with TIA or minor strokes to assess for stroke mimics and to help determine risk of a subsequent stroke. So the first best thing to do, which was already done, is a CT of the head. Non-contrast quick CT of the head needs to be done, right? So that was already done. A CTA, it's a first-line vascular imaging for a stroke and TIA. You can also do an MRA or a carotid artery ultrasound, which is the answer here. The reason for doing this is to assess for that extracranial vascular imaging. So if a CTA was one of the options, a CT angiogram, then that could be a potential answer as well. But either that, or you do an MR angiogram, not just a plain MRI, or a carotid artery ultrasound to look for the extracranial vessels that could be causing blockage. So these are all first-line tests. The other answer options, so for the sensitivity of CT for TIA or minor stroke is poor. So an MRI does provide additional information, but the big thing here is that MRIs are not easily available. And now this person is in your office 1 week later. And if you're going to try to arrange an MRI, it will not only be expensive, it will take a long time to get done. So it's not the most reasonable thing to do, because it's not locally available as widely as a CT and then a carotid artery ultrasound, which you will get much quicker. For the other options, the echo is only recommended when this is in the background of a cardiac disease. Now, there's no mention of that in the question stem here because it has low yield. So unless there's a cardiac source of an emboli suspected, so if the person has underlying AFib or something of that sort, then you would pick that as an answer. But here there's no reason to suggest that. And then the cerebral angiography, don't confuse this with CT angiogram. Cerebral angiography is actually for vessel assessment for like malformations and aneurysms. So it's not the same thing as a CT angiogram. So it's just a distractor and something to confuse you here. Chest X-ray. There's really no reason. We're not thinking anything related to the chest here, right? So we would not be picking that as an answer. So stroke best practice guidelines would be a good resource to read. I know somebody was asking about resources earlier. Okay, next question, short, quick and easy one. We'll pull up a poll quickly. Tension pneumothorax is best diagnosed with? Okay, this should be something you pick in a few seconds. You know it or don't know it, that kind of question. All right, we'll go to the answer. All right, so a lot of people pick chest X-ray and actually most people pick clinical exam and then some pick chest X-ray. All right, excellent. So yeah, clinical exam is the correct answer. Like I said, these are the ones where you get the marks quickly and you save up time for other questions. So tension pneumothorax, it is a clinical diagnosis. This is a question testing safety. If this is a medical emergency, you should be able to recognize it clinically. You listen to the chest, there's absent breath sounds, there's hyperresonance on percussion, there's tracheal shift, and you know you have a tension pneumothorax. So option D is correct. Option A and B will actually both show tension pneumothorax as well, but there's no need for these. A CT will take you a long time and you will be wasting time to definitive treatment. So yes, it will answer the question, but you don't need it. Chest X-ray, again, yes, it will answer the question, but do you need it? No. You can make the diagnosis without even sending the patient to chest X-ray. Yes, once you have definitive treatment, you want to do it, you want to confirm things, that's okay. But if you do any of the other things, you're wasting time. C, watch and wait, nobody picked this because this would actually be very dangerous for the patient. So we will not be waiting on this. Okay. All right, another short stem, thankfully. So which of the following statements about the PSA is true? So we'll pull up the poll and I'll let you guys read the answer options. Okay, let's look at the answers. Okay, so 44% said every man 50 to 74 years old should have an annual PSA test as a primary screening. 35% said best used to follow disease progression or recurrence, and then a little bit of the other answers. So let's go through this together. So the correct answer is B. The PSA is used to follow disease progression or recurrence postoperatively. So this is, as Dr. Zarka had mentioned, this is the knowledge of screening guidelines. So, this is something that you actually just have to know. And Choosing Wisely Canada and is one resource, and the Canadian Task Force both have very good guidelines of who needs to be screened for all the different cancers. So for prostate cancer, PSA is actually not a recommended screening test in Canada. So for option A, every man 50 to 74 years old should have an annual PSA as a primary screen for prostate cancer is not correct. It's not every man, so it doesn't work like a mammography where every woman after a certain age needs to get a mammogram. So this is not correct. Certain men will need it if they are high risk with a family history or personal history of prostatic disease, but not every man. PSA is best used to follow disease progression or recurrence post-operatively. This is correct, even for patients who've had prior prostate cancer. This is used as a routine, even while they're on treatment, to look for disease progression or recurrence. So this is very correct. PSA has no utility in screening for prostate cancer. That's not correct. Like we just said, certain high-risk patients, even outside of that 50 to 74 range, will get a PSA for screening. And then D, the free PSA levels are often lower in those with non-cancerous conditions of the prostate and higher in those with prostate cancer. The opposite is actually true. So free PSA levels are thought to be higher in the non-cancerous conditions like BPH and lower in patients with prostate cancer. So correct answer B. These are really good study resources. Highly recommend that you go through these before your exam. So both Choosing Wisely Canada and Canadian Task Force. Okay, so question 10. A 60-year-old man with no prior medical history comes to the ER with a 4-hour history of palpitations. She measured her heart rate at the gym 6 hours previously at 64. She's found to be in rapid atrial fibrillation with a heart rate of 160. She has no other medical history. Her labs are unremarkable. A TEE-guided cardioversion is completed in the ER, and she started on a beta blocker. Which of the following is the next best step? Pull up the poll. Okay, let's pull up the answers. All right, mixed responses. Most people have said, given the chat score of 0, the patient does not need any anticoagulation. Okay, so let's go to the answer screen here. Okay, so the correct answer is actually A, start anticoagulation with a DOAC for at least 4 weeks. Okay, so this question has multiple distractors, so I understand why people have picked one answer over the other. There is really no need to calculate the chat score in here. So they've given you all this information to confuse you and for you to sit there and calculate the chat score. But here, as you go through the question, you're seeing a 60-year-old gentleman, healthy. They did a TE-guided cardioversion in the ER, and what do you need to do next? So regardless of the chat score, you have to give them a DOAC for 4 weeks once they have been cardioverted. So regardless of the TE, if they have been cardioverted, you will give them an anticoagulation. The only important thing here is between the warfarin and the DOAC, and that's just knowledge that this is a non-valvular AFib. And non-valvular AFib means there's no mechanical valves, there's no mention of rheumatic mitral stenosis, there's no mention of non-rheumatic moderate to severe MS. Those are the 3 things. So commit them to memory of what classifies as non-valvular AFib, what classifies as valvular AFib. This patient straight up is non-valvular AFib, got cardioverted. You have to give them a DOAC for 4 weeks, regardless of the chat score. So option B, warfarin would have been correct if they had a valvular AFib. Start ASA alone. This is not correct unless we're looking at somebody with peripheral arterial disease, etc. And that's also down the road. Right now, they need anticoagulation. And then again, like I said, you don't need to calculate the chat score. So there's a lot of distractors here for a simple question. You're just going to be wasting time if you don't know that cardioversion means doing anticoagulation. There is Canadian Cardiovascular Society guidelines. Now, this is a very extensive resource, so I would not recommend that you try to learn this or try to commit all of this to memory. Do the high yield things, and it's only for reference. When you're going through questions and you're not sure of the answer, then this is the place to look for the correct answer. So atrial fibrillation, heart failure, they have good guidelines to look for sort of those basic questions that you go through and you want to look for answers. Do not waste your time reading the whole thing. I think that's beyond the scope of this exam. Okay, I think we have one more last question. So again, a short one. So ankle x-ray is required if patient reports, and then we'll pull up the answer options. Okay, let's look at the answers. Okay, so majority of the people said D, pain in the malleolar zone and inability to weight bear. So let's look at the answer. That is the correct answer. So good job, everybody. So this is, you know, knowing the knowledge of, there's no, you know, it's just knowing what the criteria of the Ottawa foot and ankle rules are. So I would recommend everybody know this for the exam, and then you should also look at the Canadian CD head rule, because most likely they will have a question on either of those, and it's just one of the ones easy marks if you just know the criteria. I have a photo here of going through the criteria. So yeah, so it tells you a series of ankle x-ray films is required only if there's pain in the malleolar zone, and then you look at the picture and bone tenderness at A or B, and again the same here if there's pain in the midfoot, and then bone tenderness at C or D. So I won't go through this just because it's something to just learn, and but this is just for your reference. You guys can take a photo if you like and commit this to memory before the exam. Okay, I think that brings me to the end of my section. Thank you, everybody, for listening and participating. I wish you all the best. I know it's very daunting to study for this exam, but you will get through it and through the rest of the process of, you know, getting a residency or whatever you are hoping to get in Canada. So good luck.
Thank you very much, Dr. Maria. It was really a very helpful session and information about the exam tips, which are really, you know, they will help for the people who are now coming for exam. So now I would like to invite my last panelist, Dr. Samina Khan. She will talk about some of the another part of the Q1 exam, which is called the CDM and ethics. Dr. Samina is an international medical graduate with extensive clinical teaching, quality improvement, and risk management experience. She is an improvement advisor trained by Institute for Healthcare Improvement and was awarded as a fellowship in quality and patient safety by the International Society of Quality in Healthcare. She has many successful corporation-wide projects on her credit. Upon moving to Canada in 2019, Dr. Samina started working as a process improvement manager at Royal Alexandra Hospital, Edmonton, while studying for her licensing exams. Samina has been assisting fellow IMGs with exam preparation since she received LMCC and runs her coaching academy, Easy Way Medicine, successfully. She is passionate about helping international medical graduates and to learn about the Canadian healthcare system and the strategies they need to succeed. In her first CALM cycle in 2022, Samina matched to internal medicine at the University of Alberta, and right now she is doing her residency there. So over to you, Dr. Samina.
Thank you, Dr. Samreen. Hello, everyone. My name is Samina, and as Dr. Samreen said, I'm an internal medicine resident at University of Alberta. And today I will be talking about two important aspects of MCCQE1 exam. The one is like clinical decision making. That is the afternoon session after the morning session of MCCQE1. And ethic, we decided to touch base this topic because this is something that we feel we as an international medical graduate has to put a lot of focus on because this is something new for us, taking care of all the ethical aspects of patient care. So I will be talking about these two topics, and I'll try to be a little bit quick in respect of the time. So So in the afternoon of the MCCQE1 exam, you will have up to 3.5 hours to complete the clinical decision-making component of the exam. And it contains 38 cases with short menu questions and short answer questions, up to 65 to 75 questions in total. So you will be given total 38 cases, but each case will have like anything from 1 to 4 questions underneath it. So total 65 to 75 questions. And you will have 3 to 3.5 hours to complete those questions. While the morning part of the MCCQE1 part exam is quite challenging in terms of time management, the afternoon part is significantly less challenging, but it has its own difficulties because you will have enough time. Attempting 65 to 75 questions in 3.5 hours is not challenging, but it has some of its own difficulties that we are going to discuss in a bit. So the ultimate message is you should not let your guard down. So within the CDM part of the MCCQE1 part exam, a single patient or family-centered questions will be there. A station will be there with 2 or 3 questions based on the introductory questions. Like multiple choice questions, CDM cases questions are meant to be answered independently of one another, and each will include several options. The CDM part of the MCCQE1 exam evaluates your ability to assess the severity of the patient illness, properly diagnose it, and select the most appropriate clinical based on the clinical scenario presented, as well as your ability to make the critical clinical decisions and appropriately manage and treat the patient. So you can see that how Dr. Maria brought up some questions to make you think that where it is just a clinical assessment and you essentially not need to do any investigations, or where the patient need an urgent investigations or interventions like a CT head or something like that. So you have to think based on the clinical presentation that what is your next best appropriate step. And just as when Dr. Maria was going through some MCQs, and you can see that almost all 5 MCQ options can be an answer, but you have to pick the most appropriate one. And I think this is the most challenging part of MCCQE1 exam, that all answers could be true, but you have to analyze based on that typical clinical scenario that is your patient that you're dealing right now in a specific setting, either in a family office, family medicine office, or in a ER, and what you will be doing next as a clinician, as their most responsible healthcare professional. So first and foremost, you need to read the instructions carefully and follow the instructions. This is an extremely important part of CDM because instructions tells you a lot, and you really have to follow the instructions, because if you do not follow the instruction, unfortunately, you can end up having a 0 despite of answering the questions right. So reading the instructions carefully is extremely important in CDM part of the MCCQE1 exam. Second, decide for the patient based on the Canadian guidelines, recommendations, and follow the protocols. Medicine can be studied from any book because medicine is medicine all over the world, but every country has their own guidelines. So when you're writing MCCQE1 exam, you have to make sure that you are aware of the Canadian guidelines, Canadian recommendations, and follow their protocols. So I think this is one thing which Dr. Maria was also emphasizing. So make sure that you know all the Canadian guidelines regarding whatever case you're studying. Your clinical experience can work for or against you here. Make sure to follow the protocol. So why they said that your clinical experience can work for or against you. So for example, if you are practicing medicine out of Canada in a different setting, you might be following a different guidelines. So that guidelines can be true, but that's like in a different setting, and we might be following a different guidelines here in Canada. So you have to update your knowledge accordingly. The other thing is time management. And as we said, that it's much more relaxing as compared to the first part, which is multiple questions. And it sure seems as you have plenty of time, but that you should lower your guard. The first thing that you will want to focus on is how you manage your time. If you find yourself spending more than 3 minutes on a question, you should probably flag the question and move on. And you can return to these flag questions at any time, or wait until you have completed all the remaining questions or cases, or when you will know how much time you have left. So definitely it is not advised to just keep thinking about one station for 5, 8, 10 minutes and waste all of your time there. So if you're spending a lot of time on one question, it means you're not sure about it. Maybe the rest of the question you're 100% sure. So it's better to just flag it, do the rest of the questions and come back to the flag questions. So instructions, the next thing is paying attention to the instruction. Each question followed by specific instructions, whether it's a multiple choice manual question or requiring a written answer, there will be specific instructions on how to answer each individual question. These instructions must be followed exactly. Your final score will reflect both the tested knowledge and how well you followed the question's instructions. There are many different types of instructions. So the questions type would be listing a specific number of answers. So for example, you may be asked to list only one or list up to two. You must limit your answer to the specified number. It is also important to only list one answer per line. Listing two answers on one line consists of two answers. You will score 0 for the question if you exceed the number of responses requested, even if you listed the correct answer. So you can see that how technical it is. And most of the time people are not aware of the instructions, or they haven't paid attention to the instructions and just went to write the exam. And even after writing the right answers, they get a 0. So all these instructions are given on the, I'm presenting them today, but you can also find them on the MCC website, how to do the CDM part of the question. Everything is clearly mentioned there, and make sure that you read them in advance, practice them, and just have them on the top of your head, because it's extremely important. So if they are asking you to just answer one, that means one. Even if you think there is another right answer, you have to pick the one best answer. If they're saying up to two, then you can write 1 or 2, whatever you're thinking. But if they say just pick 4, that means only 4. And that 4 means 1 on each line. The other question type will be selecting up to a specified number of answers. You might be asked to select up to 6 responses. These responses should be based on what you would do in the actual clinical situation, but shouldn't exceed the number indicated in the question. You may submit any number up to 6, but not more, and going over the specified number will result in a score of 0. So you really need to know what are the things that will get you a 0, because those are the things that you have to avoid in the exam. So now here, if they ask you that select up to the 6 responses, that doesn't mean that you have to come up with 6 responses. It's up to 6. So it could be 2, or it could be 3, it could be 4. It's like what you think is appropriate, putting yourself in that clinical situation. The best way of doing MCQs or the CDM part of MCCQE1, as soon as you read the question stem, think you are that doctor and what you will be doing in that clinical situation. And that will get you in a best or right state of mind to answer that question. The other question type is select as many answers as are appropriate. And these are the challenging one, because you can have a list of up to 30 options, up to 20 options. Like they can give you a long list and maybe only one answer is appropriate, or maybe 20 answers are appropriate. So if they ask you select as many as appropriate and give you a list of 20, don't think that because there is a list of 20, I have to pick like 15 at least. If you're thinking there are only 1 or 2 or only 3 appropriate answers, just go for that. So always think what is the most appropriate, or what are the appropriate things to do. If you think all of these things need to be done at some point, they all are appropriate, then select as many as you can. So it is very important to understand how the examinations will be scored. Negative markings are not given, so that's a good point. You either get 1 point for being correct or 0 if you are not. Partial marks are also sometimes awarded when more than one answer is being scored. There are 2 situations where you might score 0 for a question. So there is no negative marking. For each right answer, you will get 1 point. And as we said that there is like a station, and each station will have 2 or 3 or 1 or 2 or 3 questions. So you might get you might not answer the whole station correctly, but partial correctly. So you will get some score for that. And there are 2 things where you'll get 0. Suppose you exceed the number of responses specified in question, or you will score 0 if you select or list an item that could hurt or injure a patient. Even if your list contains the correct answer, including an option in your answer that could be harmful to the patient will result in a score of 0. Finally, remember that everything presented in the clinical scenario is relevant and you should pay attention to the details. For example, knowing that the patient is a long-haul truck driver, a letter carrier, a production line worker, or anything else is likely relevant to the case. This goes back to as soon as you start reading the question and they are presenting you the setting, the patient is presented to the ER or the patient is presented to the family medicine office, the patient occupation is this or like whatever. Think why these details are given to you, because it may have something to do with the patient condition. So always like take all those relevant information given in the questions in account. So with this, there are different types of instructions. So we already went through those. With this, we will come to do some practice cases. And let's read the question and then you guys can write the answer. So 65-year-old man presents with sudden loss of speech and difficulty swallowing while watching television after his breakfast. On examination, his pupils appear asymmetric and deviated to the left, and gait is ataxic with weakness in the right arm. So question number 1 is, what are your differential diagnoses? Include up to 3. How will you manage the patient? Indicate up to 3. And his condition has been managed and now he's ready to be discharged. What will you advise? Indicate up to 5. So this is a write-in question where you have to write answers to each one of these questions. So I'll give you 2 minutes to write answers in the chat box and then we'll take it from there. Okay, it seems like we got some answers. So let's see. So IMS, right-sided hemiplegia, stroke, LMS, cerebral stroke, brainstem stroke, cerebrovascular accident, brain hemorrhage, epilepsy, stroke are differentials. And you will be doing CT head and therapy accordingly, CV, CT head anticoagulant. Okay, so it seems like we didn't reach to all the answers because there are 3 answers that we need to answer here. So I'll go through the answers myself. So what are the differentials? Indicate up to 3. So it's up to 3. So you can write 1, 2, or 3, whatever you're thinking of differentials. So I came up with ischemic stroke or Bell's palsy, or it can even be transient ischemic attack. How will you manage the patient? Indicate up to 3. So now this should be like, the immediate managing step that we need to save the patient. And that could be investigation and could be like as Dr. Mari indicated, management include everything. So urgent port stroke, non-contrast CT head, and urgent neurosurgical consultation. His condition has been managed and now he's ready to be discharged. What will you advise? Indicate up to 5. So antiplatelet therapy, manage hypertension or ACE inhibitors, statins to manage his dyslipidemia, and smoking cessation. So you're advising a multidisciplinary team for stroke rehabilitation. So the most important things or appropriate steps that need to be done for the future prevention of the stroke. So basically you are controlling the risk factors, both by the medical therapy as well as by the modifying the risk factors in that person's life. You can start them on antiplatelet, managing the hypertension, but if they are obese and not losing weight, or if they're smokers and not quitting smoking, so those things like you're not modifying their risk factors. So you can come up with both medical therapy as well as modifying some of the risk factors. So you will have this kind of questions in CDM where you will have to answer where you have to write in type in your answer. So definitely you will have no help. You just have to come up with your own brain. So you need to know so I think the best step in this case scenario is when you're preparing for MCCQE1, and it will helpful both for your MCQs part as well as CDM part, stepwise approach, stepwise management. That if the patient is presenting in this, what is the next best step I'll do? After that, what is the step? After that, what is step? So you should have that stepwise approach, and that will help you to come up to answer all these MCQs and CDM. So the next question is, a 20-year-old female present to your office requiring OCP. So what questions would you consider asking her before the prescription indicate up to up to 7? And you will prescribe the pill and the patient started to take them, but she returns to your office after 2 months because she forgot to take the pill for past 2 days as she went for a business trip. What would you consider at this point indicate only one? So have 1 minute to answer these two questions. Type in your answers in the chat box. And I'm sorry for my voice. I'm under flu. Okay, some of the answers that we have: smoking history, current medications, give emergency contraception, family history of DVT, prothrombotic events, hypertension, personal or family history of breast cancer, LMP, history of liver disease, a history of AUB, history of DVT, history of breast cancer. So Raj, I like that you tried to pick up to 7, or like, do you try to pick as many things as you want to ask the patient? Because all these were one, and I understand here we have the time limit and this is not the perfect platform to answer these questions. But like when it's like up to 6, up to 7, you actually have to come up with the list of like whatever the appropriate questions you want to ask to the patient. The only comment, Raj, and I understand this is like Zoom and the webinar, so they all are in one horizontal line, but I just will utilize this opportunity for teaching purpose, that in exam, LMP is one line and your history of liver disease will go into line 2, your history of AUB will go into the line 3. So this is what I was telling you before, that you should not answer 2 questions in one line for the real exam. Here I'm of course accepting it, but like when you're answering all these questions, they should go line by line. And did anyone answer that if you want to ask that one question, that is stop and start again in the next cancel one? Biggest problem, do not know what is OCP, what is advice. Okay, and start over with the course. Okay. So the biggest problem, if you don't know abbreviations, I'm sure that in real exam, they won't be using abbreviations as far as my knowledge concerns. I think they will give you the whole term. Or even if the abbreviation is there, that will be something which is so common that everyone knows it. But mostly for the real exam, they don't use abbreviations. Even if they're using oral contraceptive pill, and then in the bracket, they can write OCP. So I don't think so this is going to be a problem for you. The other question 2, if you read the question 2, it was, you prescribed, what would you consider at this point? So the answer, many people said that stop it and start from the next cycle. The answers that I have, so these are like, last menstrual period, past history of migraine with aura. So typically you are going to prescribe them oral contraceptive pills. So before prescribing those oral contraceptive pills, you have to rule out the absolute and the relative contraindications of the OCPs. So definitely write down all the absolute, and because it's up to 7, and then you can come up with some relative contraindication as well. But those are the most important things, because you cannot give anyone an oral contraceptive pill without ruling out the contraindication. So, they could have asked you a simple question: what are the contraindication of OCP? But that's not how they structure the questions in MCCQE1. They structure them differently, but the meaning is essentially the same. So now, what would you consider at this point? Now the answer, which is like, stop it and start from the next cycle, that is a logical answer, and you can advise them to use some other form of contraceptive meanwhile. But the most important question in all such circumstances, or the next best question in all such circumstances, is when was their last menstrual period. So it is like coming down to, again, the answer that you wrote is correct at one point, but the next question, the next best question that we would like to ask is their last menstrual period, because you want to make sure she's not pregnant already. Okay, this is the third question, case third. A 47-year-old male presented to the emergency department with executing chest pain, which goes up to his jaws. The pain started suddenly and is continuously worsening. So what essential steps in initial management warranted? Indicate 3. Patient is now stabilized. what further step would you like to do? Indicate 5. So check vitals, ECG, trop, GTN, EKG, echo, timing of chest pain, pain control with morphine. Okay, EKG, cardiac markers, aspirin. So let's see. So what essential step in management are warranted? So first of all, I want to bring you to the indicate like instructions. So this says indicate 3, this says indicate 5. So remember, I asked you to read the instructions properly. So it's not up to 3, it's not up to 5. So they have indicated a number. So means you have to give 3 answers. If you're giving less than 3 answers, so you're already compromising on your score, because the answer, the right format is to answer 3 there. So EKG or electrocardiogram, analgesia for pain relief, and urgent cardiology consultation. And indicate 5, consider reperfusion therapy, manage reversible risk factors, ACE inhibitors, statins, and antiplatelet medication. So I read someone wrote echo. So remember, they said the initial step in the management. So echo is, we don't do echo until the patient is like, stabilized and maybe even ready to discharge, because we typically do echo to learn the complications and what are the risk of complications, what complications already being developed, if any. So you have to pay attention that what they are saying, essential steps in initial management. So you have to make sure that, and once you have stabilized the patient, so seems patient is like, after the initial management, now what are you going to do? So you, as soon as you receive the patient, you are doing an EKG, you're giving, because patient is in severe pain, giving the pain, and you're calling cardiology because you want helping hand there. Patient is having an ischemic attack there. And then immediately you will be thinking like, if EKG shows USD elevation, are you going for the reperfusion therapy? You're managing reversible risk factors, ACE inhibitors, statin, and antiplatelet medications. These questions also tell you, remember when we did the stroke case and we said quote stroke, and when we are doing here the initial management, we are calling urgent cardiology consultation, because these cases are presenting in emergency department, and you are the ER physicians who is doing the initial management, and you have to make sure that you have the right appropriate services on board, because if you're going for reperfusion therapy or anything, you cannot do it yourself. You have to have a cardiologist on board. So think like, analyze that what are the exact initial steps that I should take to serve this patient best. Okay, so practice 4, patient brought a 5-year-old child to your clinic with complaint that he's still bedwetting until now. They tried different ways, such as restrict the fluid before he goes to the bed, getting him up from the bed and wet alarm. He's a healthy child except for an old scar in inguinal region, and he's mild hyperactive. Urine analysis has been done and the result showed it is normal. Which one of the following will you ask the parent to exclude the organic lesion? Choose as many as appropriate. And can we have the pool up, because now it's a little bit easy. So we'll have the pool up and you guys can pick. Okay. So a vast majority of you picked daytime wetting, frequency of urination, diurnal wetting, disturbance of sleep, encoparesis. So let's see. So answers: daytime wetting, moved recently, frequency of urination, parasitic infestation, and encoparesis. Now, what investigation would you like to do, if any? Can we have the poll up? Okay, yeah, we have it. No, it's the same one. Do we have the pool for this one? What investigation would you like to do? And if you don't have the pool, that's fine. You guys again type in the chat that what investigation would you like to do? Okay, so I think I didn't put the answer for this on there. So you're right. If we have having all those things, the only investigation we would like to do will be the urine analysis to make sure that the child is not having any urinary tract infection, and it's like an easily simple test to do and not that costing a lot, and ruling out infection which can be treated. But apart from that, you won't be doing any other test and reassurance and management. Okay, so I have some more questions, but I will not go through those because I think the main idea of doing these questions with you guys to give you an idea that what we have to do, we have in respect of the time, because I still have to go through the ethical case scenario, and I think that's a very important topic. I'm not sharing the rest of the CDM questions, but I think that you guys got the major point regarding the instructions, where you're going to get 0, what is up to 5, what is the only 1, what are the typing answers, and what are like choosing the answer. So just prepare like that. And the other thing I would say, prepare all the most important, like, case scenarios, which is like everyday presentations in your daily life in medical office or ER cases. I would say like all the NACOSCI cases that you typically prepare, those are the cases that you should prepare for your CDM part of the exam as well. Okay, so let's move to our next part, and that is our ethical part. I'm just pulling up my presentation. Just bear with me for a minute until I get it up. Seems like technical issue there. Okay. So for some reason, I'm not able to pull it up on my screen, Dr. Saad. So if you can pull up the ethical presentation for me, please. It's the first one. Yes, thank you. Okay. The principles of the healthcare ethics are essentially 4, and they are extremely important. So the first healthcare ethic is autonomy. The next slide, please. So autonomy in medicine refers to the right of the patient to retain control over his or her body. A healthcare professional can suggest or advise, but any actions that attempt to pursue or coerce the patients into making the choices are violation of this principle. In the end, the patient must be allowed to make his or her own decisions, whether or not the medical provider believes these choices are in the best interest of the patient, independently and according to his or her personal values and belief. So what does it mean? That in Canada, patients have autonomy. That is, they have the right on their body. Being healthcare professional, your expected or your duty or responsibility is to give all information to the patient regarding their medical condition, the risk factors involved, what could be the prognosis of this medical condition, what are the treatment options, what are the alternative if the patient do not take or is not willing to take the standard treatment options, what would be the complications of disease itself, or what would be the complications of treatment. So it's like giving all these information in detail to the patient in simple most language, so they understand what is going on. But then let them decide, let them make a decision for themselves. Do not influence their decision by any means. You can tell them evidence-based what is the best practice, but then let them choose for themselves. So you cannot influence their decision. Similarly, family cannot influence their decision. It's the patient himself or herself who will make decision for themselves. So this principle of ethic is called autonomy, and every competent patient have the right of autonomy. And we will talk about what does it mean that every patient who is competent have the right of autonomy. So can we go to the next one? So the next principle of the healthcare ethics is beneficence. And this principle states that the healthcare provider must do all they can do to benefit the patient in each situation. All procedures and treatment recommendations must be with the intention to do the best for the patient. To ensure beneficence, medical practitioners must develop and maintain a high levels of skills and knowledge, make sure that they are trained in the most current and best medical practices, and consider their patient's individual circumstances. What is good for one patient may not necessarily benefit the other one. So this is simply means always try to do good to your patient. So that also means you have to constantly keeping updating your knowledge as well. You have to be familiar with the current guidelines, and the information that you're giving to the patient, they should be accurate and they should be evidence-based and the most current ones. And again, when you're treating the patient, you have to keep their individual circumstances in vision, because maybe one thing which is best for one patient might not be best for the other one. But your intention should always be trying to do good to the patient. That is the basic core principle, beneficence. The next principle is in line with to that. Can we have the next one? And that is non-maleficence, that is avoiding harm. So this is the best known of the 4 principles, because simply do not harm your patient. So this principle is intended to be the end goal for all the practitioner decisions, and means that medical provider must consider whether or other people or society could be harmed by a decision made, even if it is made for the benefit of an individual patient. So this is like, where you are trying not to do harm to the patient. And this is like a wide spectrum thing, because along with not doing any harm to the patient, you also have to consider avoiding any harm to the other individual and the society as well. And the last one is justice. And justice means a fair and transparent healthcare system where everyone is getting fairness in decisions that burden and benefit, as well as equal distributions of resources and new treatment, and for medical practitioner to uphold applicable laws and legislations when making choices. So you have to make sure there is a fair system in place. For example, if someone is need to get into the kidney transplant waiting list, they should get there by the existing eligibility criteria, which is usually set standard by the hospital committees. And the patient should meet those requirements, depending on their medical conditions, comorbidities, all of those other factors. But it should not be influenced that the patient is your relative, or the patient is your very good friend, or the patient because it is related to someone. So means there shouldn't be any biasness there. There shouldn't be any treatment given to the patient because the patient, or any unfair treatment there. So justice is another core principle of healthcare ethics. So now let's go through a hypothetical scenario in the next slide. So in this case study, if there is a patient who has an ovarian cyst, and that ovarian cyst, if left untreated, will result in kidney failure because it's growing in size and causing post-renal obstruction and putting the patient in renal failure. So what is the best treatment here? That you remove the cyst so patient do not get into the renal failure. So doctors explain all of this to the patient, that you have a cyst that need to come out because otherwise it will keep growing and it can cause obstruction, ultimately leading to the renal failure. But the patient is afraid of needles and doesn't want to have that surgery because very afraid of needles. So now if the patient refused the surgery after knowing what is happening, what is the best treatment for that, everything, this is their autonomy. They have the right to refuse that treatment. Although this is the best treatment that they can get, this treatment is in the best interest of the patient because you want to do that to prevent a kidney failure there. and you have explained it to the patient, because this is patient right to know what he's having or what she's having and what could be the ultimate cause if left untreated. But after knowing all that, if the patient is still saying, no, I don't want a surgery, this is autonomy. Patient has the right to refuse, even if you think it's in the best interest of the patient. Now, patient refused the surgery. They don't want to go ahead with it. So does your role as a doctor end? Because you explained to them everything so nicely, you gave them the best option for them and they refuse it. So what will you do next? Will you just abandon them that, okay, then you can go out and we will not see each other again? No, you're still the healthcare professional. You're still the doctor taking care of that patient. So now patient doesn't want the surgery. So you will try your best to come up with another alternative solution, or try to do like some, like explore other options with the patient. And that's like you're trying to do good, you're trying to benefit the patient. So this is the beneficence of the patient. And non-malfeasance is like, um, patient is afraid of needles. So you are, if you're like, overruling their autonomy and just giving them still like going ahead with the anesthesia or like surgery and giving them those needles, and then essentially you're causing harm to the patient, which shouldn't be there. And the last is one is justice. And here, I think this will come as a very clear that what does justice mean in Canadian system, because we covered that we shouldn't give any biased treatment to anyone, but at the same time, we have to be aware of the consequences as well. So for example, this patient who need to get the surgery done to remove the ovarian cyst, so that patient doesn't go into the kidney failure, but patient is refusing, and we are respecting the autonomy of the patient. But then we also have to explain to the patient that refusing that surgery means going into kidney failure, which means they will ultimately need dialysis. Now, we have to be fair with other patients as well, because this patient is going to have the need of dialysis because they refused to something which was preventable, as compared to someone who went into the kidney failure because that was unavoidable or unpreventable. So then who will get priority in getting the dialysis? If we have that competition there, or we have that priority there, then definitely the patient who went into unpreventable renal failure will get the priority, because the other patient is like, intentionally going into a direction where they will have the renal failure. So you will explain all those to the patient, and you will be fair to the other patient. So this is like justice, distributing the resources like equally, fairly, and making sure that when you are explaining the patients everything, it covers. Because if patient has autonomy to make a decision for themselves, they should also know the complication and what will happen if they end up on those complications. Can we go to the next one, please? So while answering your MCQs questions or your CDM question, always keep all those 4 basic concepts of ethic in your mind. And then there are certain things like capacity. So now what does it mean by capacity? Because capacity means like someone has the capacity to make a decision. It is like, remember we said for autonomy, you have to explain everything to the patient so they understand and make an informed decision for themselves. So you're explaining everything to your patient, but the most important question is, are they competent to understand what you're explaining to them? Are they do they have the ability to understand relevant information, ability to appreciate the consequences of whatever decision they make? Specific decisions under questions. A patient is capable if she understands the nature of the disease and understand the consequences. So then you will call them competent, because if someone is not even understanding what you're explaining to them, that patient is not competent. And there is a whole way of doing capacity assessment, which a person may be capable at one moment, but not at other. Maybe someone is in delirium right now, like not in right senses or confused, and whatever you're explaining to them, they are not understanding it. By the morning, they clears up and you have the conversation with them again, and now they understand. So they were not competent in the night, but they are competent in the morning, and vice versa. Maybe they were competent in the night, but in the morning, they are all confused and not able to understand. So there are like capacity assessment that you can do some certain questionnaires yourself. You can get it assessed by the other physicians. You can review the old charts and everything. And sometimes, like if it's very difficult that you're not able to understand whether the patient is competent or not, you can even involve a psychiatrist in the examination and get the capacity assessment done. Because remember, to exercise the rule of autonomy, the patient should have the capacity to make a decision. Can we have the next one? So what if the person is incompetent? So there could be situation, and this is like everyday life where we face certain situation where the patient do not have the capacity to make the decisions for themselves. In that situation, we have two options. Either we will look for a substitute decision maker or something called advance directive or another legal document like a power of attorney. So what is substitute decision maker? Substitute decision maker is like someone who can make a decision on patient's behalf. That could be your spouse, that could be siblings, that could be parent, that could be a neighbor, that could be a friend, anyone who is trustworthy by the patient. And they have appointed them as their substitute decision maker, that when God forbid, they are in a condition where they are no more able to make decisions for themselves, then their substitute decision maker will make a decision. And I want to bring one point into your notice. This, for example, someone is delirious or in coma and cannot make decision for themselves, and substitute decision maker has made the decision for them. But if that person is back from coma and no more delirious, they get their autonomy back. So then you're not going for substitute decision maker. Now the patient has the capacity, so they has their right of autonomy back as well. So the other thing is, if patient do not have or don't want to have a substitute decision maker, they can also have an advance directive, which essentially a written will or something called a power of attorney, where patient can write in advance that what do they want if they get to that stage where they are not able to make a decision for themselves. Do they want any resuscitation? Do they want to go to the ICU? Do they want a breathing tube in? Do they want any kind of treatment, or they just want the comfort care? So they can write it down, everything in a document. So when you're dealing with such patient in MCQs as well or CDM, patient is like now incompetent, you will look for a substitute decision maker, or you will look for an advance directive, and whatever you get hold of, you will make the decision according. The next slide. Can we have the next slide, please? Now, autonomy is limited in cases where there might be harm to him or her or others. So as we said, that patient has the right to refuse the treatment or everything on their body, but it could be like limited when either patient can be harm for them or harm for others. So best example is, someone who has suicidal ideation and they want to kill themselves. So they don't want to get admitted in the hospital and they want to leave. Autonomy says that the patient has the right to make decision for themselves, but in this case scenario the autonomy will be limited, because that this is not good for the patient. They will go out and kill themselves, so they will cause harm to themselves, or they will go out and maybe kill someone else. So in that case their autonomy will be limited, and you can actually take decision for them on their behalf. So in certain circumstances autonomy will be limited. Now, what about children? Because that's another important thing, and you will get tested in the exam. So usually in most of the cases, it's the guardians who make the decisions for the children. However, what is the most important thing here in Canada, although for children, most of decisions are made by the guardian, there are certain circumstances where the decisions are still made by the children, even if they are they are not fully adult and they are still in their teens, like 13 years old or 14 years old or 15 years old. And those are for example, treating sexually transmitted infections, prescribing oral contraceptive pills, doing an abortion, all those kind of things. If it's a teenager who is competent enough to make decision for themselves and they want the privacy and confidentiality, that they don't want to share this information with their parents, you will respect their privacy and you will go ahead and treat them on their own wish without involving the parent. And this is another heavily tested subject in the exam, where they will give you scenarios in which 13 years old coming and asking for oral contraceptive pill. as the guardian has to take the decision, so you think to ask the parents, but actually here you won't be asking the parents and you will be treating them, you will be giving them OCP. And similarly with, if they want to have any advice regarding the sexual intercourse or all those kind of things. So do read into these, that which are the things where the autonomy is posed to the patient or the teenagers instead of parents. Okay, the next slide. So emergency treatment, that's another question, and this is also heavily tested in exam. That what about in emergency situations, like someone coming in a shock, someone coming after a trauma and not able to communicate, not in a position to communicate. So the healthcare practitioner may administer treatment if the patient is incapable. Then you can do anything to save their life. The person is experiencing severe suffering. Suffering would be prolonged or bodily harm may occur if the treatment is delayed. In that situation, you will go ahead and treat them. Next. So ethical principles are guidelines, and some cases can get complicated. The good news is there is an ethic committee in most of the hospitals, and if a committee is not available, there is always a more experienced consultant. So when uncertain, ask for an ethical consult. So this goes for the exam as well, that in exam, if you really don't sure that what are the options that you have to pick, and there is an option like, getting the ethical consult, you can pick that option. Okay, so we have some MCQs there, but do we have time to do that, team? Dr. Saad, Dr. Tahmina?
Yeah, we can do a few questions. Go ahead, please.
So we'll go ahead and do some questions. So the first question is, a 43-year-old male patient asked for a privately paid for gold crown on his upper right lateral incisor. He wants to have it done within his culture. It is a symbolic of wealth and good fortune, and it would, he says, elevate his social standing. The patient is an irregular attender, like he misses appointments, but his oral and dental health is good with no decay or a restoration present. In deciding whether or not to assess his request, what are the competing principles here? So pick one. Can we have the poll up for this question? Okay, can we have the answers, please? Okay, so seems like there is a tie between option A and option B. So let's see what we have on the slide. So the answer is B, autonomy, malfeasance, and justice. So why we didn't pick the A, which some of you picked, like an equal number of people were there, because there is like no benefit if you see. Patients, remember in the question stem, they said there is no decay, dental health is good. They want to do it for like elevating their social circle. So essentially there is no good involved to the patient. But the only principle that you have to consider here, not doing any harm to the patient. And of course, autonomy, that they have the right to choose what they want to do for themselves. And justice, like when this patient is going for this crown for a social reason, you have to make sure that the other people are getting the equal treatment and there is equal distribution of resources and everything. So these are the three competing ethical principles in that scenario. Question 2. So after attending his new dentist, a few weeks for a course of treatment for replacement crowns and bridges, Mr. Watchful has noticed that the dentist would leave the room and come back to carry on treatment without changing his gloves, and also often took instruments out of the sink to use on him. At the final appointment, Mr. Watchful challenged the dentist on this, who just shrugged and said he had practiced like this for years, as did many of his colleagues in the area, and there never had been a problem. So which one of the following statement is correct? Can we have the poll up? Okay. Can we have the answers up? So most of you answer E, and that's the correct answer, because whether or not the patient is getting any harm, the practice is wrong. So the dentist will still be getting, like, when there will be a committee and there will be a review of this case, he might have like, some adverse findings there, because whether Mr. Watchful had any side effects or not, the practice itself is wrong. Can we have the next question? A patient allows you to take series of digital photographs of his diabetic foot wound. In which one of the following situation is a further specific permission from the patient not required for subsequent use of these images? So you took these pictures, and when you don't need permission, and you can still use those images. Can we have the poll up, please? Okay, can we have the answers up? Okay, and you all, majority of you are right, allowing access to these images by a wound care nurse in the same practice. Some of you did pick some other questions. So privacy and confidentiality is taken very seriously in Canadian healthcare system, and this is some of ethical point that you guys should remember. Patient privacy and confidentiality is extremely important. You cannot share patient information even with the spouse or with the parents or with the siblings, anyone without the patient permission or without patient knowing and giving you that permission. Similarly, if you have taken photos, first, you cannot take the photos of the patient without seeking the permission. And even if you have taken the permission and you took the photos, you cannot use those photos without patient, again, without patient permission. However, there are certain circumstances where you don't need the permission, and that is called circle of care. That's another concept of ethic that I want you to read about, that who are the people in the circle of care. So circle of care essentially means you're treating, or your healthcare team, which could have a doctor, a nurse, a pharmacist, a wound care, a dietitian, a nutrition, a physiotherapist, like anyone who is involved in that care, in the care of that patient. They are the circle of care of the patient. So then whatever things that you are retrieving from the patient, their information, their pictures, the circle of care people are entitled to use those without having repetitive permissions. So other than that, every other option was wrong, because for every other option, you have to seek permission again from the patient. Can we go to the next question? So remember privacy and confidentiality. So question 4, a patient can be considered to be competent to provide or withhold consent on their own behalf in relation to a treatment procedure proposed for them if certain conditions are satisfied. Which one of the following is not one of them? So this is also a question where you have to think a little bit. Okay, can we have the poll up? Okay, so they have a similar procedure carried out, 91%. Can we see the next slide for our answer? So they have a similar procedure carried out in the past, so it is reasonable to assume. So this is the wrong answer. I mean, this is the right answer. Why I said the question is technical, question is a bit technical, because remember they said which one is not. So that means the other 4 options are true. You have to pick one option which is which shouldn't be done. So that essentially wrong in that scenario, and that is the right answer. So you will get a lot of such questions in both MCQs and CDM part. So make sure that you're getting it accurately, which seems like you did, because 71% people did reply nicely. So I think the last slide has some resources. If we can go to that point, Dr. Sad, just quickly to the last slide. I'm okay. Don't, but anyway, I'll discuss with it. So I did have some more questions, but because I think with question and answer, the challenge was time management, and we just went over time. So how to prepare for these ethical questions? CMPA website is your choice. That's all the Canadian legal things and ethical things. You can also read Doing Right or 100 Cases by Conrad Fisher. But if you're reading Doing Right or 100 Cases of Conrad Fisher, you have to make sure tally them with the Canadian system, because those are American resources. So you can get an idea. And most of those things apply in the Canadian system as well, but then there are some variations. So go through the Canadian resources as well. That's your Toronto North or your CPMA website. And with that, we will conclude our today's session. I think we'll take your questions now. So I'll hand over it to Dr. Wasia. Thank you, guys.
Thank you so much, Dr. Samina, for very thorough discussion on CDM and ethics. So we have been getting lots of questions in the chat, and a lot of them have been already answered. But I have few of them in with me. And, I will read those questions, and then I will request my panelists, anyone who can answer those. So my first question is QE1 is the only licensing requirement to work in Canada? So anyone who can answer for me?
I can take that answer. So to work in Canada, there are different pathways, guys. So one is like residency pathway, and the other is practice ready assessment pathway, or the specialist pathway. So there are different pathways to enter into the Canadian system. Essentially, in whatever pathway you follow, whether residency, whether practice ready, whether specialist pathway, you still have to do MCCQE1 exam. That's a must. So it's like a must exam. And then the other exam that you need is NAC OSCE. So these are the eligibility criteria. But then a third exam is your IELTS, or like others English proficiency exam, your language proficiency exam. And then there are certain other requirements. So for example, if you're going for the residency, you have to write some ethical exams as well, which are different from different provinces. So I think the best thing is like, it's a very journal here that what is it the only thing. Canada, there is a central system, and then there is a provisional, and every province slightly different from the other. And then there is CAMS, which is residency. So you all are different, applying to different routes. So I would say all the information are given to on the respective websites, and those are your best resources. So use those resources to educate yourself that what is needed. At the same time, all of those websites, they have contact details. And trust me, the Canadian peoples are very good in getting back to you. So if you have a question, just write them an email and you will get the answer.
Okay. Thank you so much, Dr. Smina. So my second question, actually part of it you have already answered, but the question is, how many exams do we write before applying for residency?
So we'll pass this because we said it's QE1 and NAC. There used to be QE2, which is on hold as of now. So it's on hold. So QE1 and NAC and English, your language proficiency and some ethical exam. So again, go through the website and you'll get the answers.
So my next question is, what is the how long does it take to complete all the exams? So anyone who can answer.
I can take that. I guess it depends on how far you are from graduation or from doing some other exams. So there's no true answer. Like for myself, I took the MCQE1 and the NAC together, like 1 month apart, but they were a year apart from the MCCE at the time. We don't need the EE at this time. So it just depends on how close to graduation you are, how well prepared you think you are. The QE1 and NAC test very different things. So not necessarily that you have to do them together, but keep in mind the timeline of the CARMS you're going to apply to for residency. That would be the main thing, to do the exams before that.
Okay, yeah, thank you so much. So next question is, what is the scope for someone with 6 to 7 year clinical gap? And another participant asked the same, like, what is the scope of residency for an older person, like who has gap and now they have getting older?
Yeah, I think I can give the answer for this. So I also got a residency after a few years of gap. And I think Maria has in the chat wrote quite, given quite information about that. So I think do the observerships, make your, get the referrals from here. And so clinical assistant program is another good way to go, because if you go into that system, then you will get the Canadian experience here. So I think it's not only the medical what experience you had from the past, but you can make more experience working in observerships, whether in the clinics, whether in the hospital, part of some research team. And this will, your CV is not about your experience back home, but also you can make your CV here, working here, and getting good referral letters. So yes, this is possible. We have seen lots of people getting into the residency at a very later age with very huge gaps. So this is possible.
Okay, yeah, thank you so much, Dr. Zarka. So next question is, how can we work as a medical officer after writing licensing exams? So anyone who can answer.
Medical officer, is this in the clinic? So I don't think you have, if it's in the clinic setting, medical officer, I think you do not have to have any experience. It depends on the clinic. I think you're talking about MAOs.
Yeah. I can take that, Dr. Zarka. So I think if it's a medical officer, if you guys are talking about the medical officers that we have back home, like in Pakistan, India, or like all those countries, unfortunately, that do not exist in Canada. You cannot work as a medical officer in Canada. Because back home medical officer is a licensed doctor who work, right? So you cannot work after getting through these exams as a medical officer. So essentially, guys, these exams are just licensures. These are not licensed. So even after clearing this exam, you do not have any license to practice until and unless either you get into residency or you get into a special pathway like a PRA route. So you cannot work as a medical officer. The only things you can work as a clinical assistant, which is very similar to medical officer role in Pakistan, but the title is clinical assistant. These are restricted license positions in certain provinces like Alberta, Manitoba. British Columbia has started it last year. So they give you restricted license to practice in tertiary care hospitals under supervision. So those are clinical assistant positions. But other than that, there is no medical officer role here in Canada.
Okay. Thank you so much. So my next question is, what are the minimum scores required for QE1 exam?
So it's 226 to pass and 1375 to pass in NACOSCI. However, I would not recommend you to get the minimum score, passing score, until and unless it's a specialized pathway or PRA route. If you're competing for residency, you should target to score high.
Okay. Yeah, so next question is, where can people access free resources for guidelines?
I can take that. So there are tons of resources. I mentioned a few as I was going through my slides. So go through, there's society guidelines, and then there's, so choosing wisely, I would say Canadian Task Force, those are good for like primary care topics, screenings, and all of that. Each of the societies have guidelines, so Canadian Cardiovascular Society, Stroke, OB-GYN Society, but I would say do not get into the depth of those because those are quite extensive. I use them as references when you answer questions to go back and look at what the society is telling you, and I think that should be sufficient for that. You can read a brief explanation, because if you start reading them, there's no way you can remember, and those are actually things that we study for when we're doing our Royal College exam, so I don't think it's in the scope of this exam. So those are some guidelines. I think Dr. Samina mentioned some as she went through her slides, and we can probably write some on the chat as well, so everybody can note them
And
down.
also, if you want to know like resources, free resources available, if you are in if you're in Canada, there are tons of free resources available. If you're in Ontario Health Force, if you're in Alberta International Medical Graduate Association, then there are Facebook group, like a huge Facebook group like MCCQE1 study group. I found all of these platforms very helpful. There are tons of resources available. There are tons of people who are there to guide you, help you, connect you with the right resources. So utilize, like, we are in an era of technology, so utilize these resources.
Okay, thank you so much. So my next question is, how much clinical work is needed after gap for residency of practice?
So if you're going for residency, there is no cut-off. Residency is preferred. It can be anywhere, like, from 3 months to 6 months to 1 year. The more it is better. However, if you're targeting a clinical assistant position, recently they have set up a criteria of at least 1 year of residency in the last 3 years. But for residency, there is no such restriction, but it is preferred that you do some kind of residency, even if it's free.
Yeah, thank you so much, Dr. Smina. So my next question is regarding 3-day cuff MCQ. I think that's Dr. Maria, she can answer about. Should we have treated cuff but that's not an option in the answer, but anyone wants to elaborate on it?
Yeah, so I mean, you know, don't treat symptoms, you should treat the underlying problem. The cough with a viral infection will resolve on its own. You know, and it's not recommended to suppress the cough. If you can bring things up, that's better. If the cough is, you know, subacute, goes beyond 4 weeks, up to 8 weeks, and you still think it's viral in origin, like it's post-viral bronchitis, the guidelines, like the Thoracic Society guidelines, recommend like antihistamines. You can use first generation antihistamines or decongestants. It depends. For chronic cough, then you're going into a whole other territory of what is the underlying cause. Is it GERD causing the chronic cough? Is it, you know, malignancy associated? What is it associated with? But generally speaking, it will not be an answer that you just treat the cough. You should either treat the underlying problem or let it self-resolve.
Yeah, okay, thank you so much. So my next question is, I am 40 years old and done my FCPS and working in Pakistan. How can I pursue my career in Canada? So anyone who can answer this question.
I think I can take this question. I read it in the chat as well. I think you said you have FCPS. And so the first part of the question, age doesn't matter in Canada. You can match even at the age of 50, 47, 48. Age doesn't matter. That's a good news. The other thing, you have FCPS in Pakistan. That's a great thing. I think you should look into the practice ready assessment pathways as well as the specialized pathways on different provinces websites, like, you know, the Alberta website, Ontario website, British Columbia website, to see if that is something you can look into. And if you are not fulfilling any of those eligibility criteria mentioned on those websites for the specialized pathways, then see if you can follow up any of the practice ready assessment pathway. Even if you cannot do that, you're still in Pakistan, I would say, then don't come to Canada before completing your 2 years of family medicine diploma. Do that family medicine diploma, and then definitely both the PRA and the residency pathway is open for you. I feel the people who are still not in Canada are the lucky one, because they can still do certain things before moving to Canada to better prepare for themselves. So ultimate answer, you have chances, you have great chances. Just you have to make sure you're doing right things before moving to Canada and after moving to Canada.
Yes, thank you so much. So my next question is, what is the best preparation course for QE1 exam?
This is a difficult one to answer because I don't think we can endorse any particular course as being one thing. The second is I did it without any preparatory courses because I wrote it before I actually moved to Canada. There is various associations. I don't know if we're in the rights to mention the names. I'll maybe leave Dr. Thamina to write it in the chat if we can. But yeah, I mean, the best reason, like I used Toronto Notes back in the day, but I would say it's more helpful to know Canadian guidelines more so than anything else, and do questions. I don't think we can endorse particular courses.
Okay, thank you. So my next question is, recent associate registration category require 1 year experience with QE1. Is that still need?
So I answered this question already, Dr. Gosia. So this is for the clinical assistant that they need 1 year.
Okay. So my next question, 1 year house job training, is it transferable towards applying for Canadian licensing?
Unfortunately, no.
No.
So, okay.
Yeah. It can be used as that 1 year clinical experience for applying for CA jobs, because I have done that, but not for residency, no.
So my next question is, are exam objectives given on MCC website with study material, and what question bank should we use for preparation?
Again, I think it's hard for us to tell us which bank or which study materials you will get that, but those objectives are all available on the Medical Council of Canada website. I think Maria said that we are not.
So I just take these questions, Dr. Durga. So yes, the MCC objectives are given on the website. All the information regarding CDM are given on the website. The one thing that I would really encourage to do the practice test that MCCQ website like the MCCQ have their own practice test. They are a bit expensive that I would really encourage to do that because they give you an idea where you are. So anyone who is scoring more than 70% in MCC practice test actually are safe to enter into the exam and score high. So just know that what you have to do before the exam. Regarding other QBank, UWord is a great resource to study medicine, but it is totally not what you're being tested in the MCCQE1 exam. So if you're reading UWord to gain medical knowledge, great. But make sure that then you do study from a Canadian resource because the type of questions, the content of question is totally different from you.
Okay, yeah. Thank you so much, Dr. Spina. So my last question is, how can I get visa to write NAC and apply for CAMS?
So visit visa if you do not have a status. And I would also like to elaborate on one because recently I saw some questions regarding this on one of the Facebook page as well. Unfortunately, guys, Canada is not like US or UK where you write the exam and you get a visa to practice or like start your residency. In Canada, you need to have a legal status to apply for any of the position for residency, for PRA, for specialized pathway. So that's only possible through immigration. So either you should be a permanent resident or a citizen. Otherwise, you are not allowed. Even you are getting done with all the exams, you can do the exam by getting a visit visa. But after getting the exam, to be eligible to work as a doctor, you need to have a legal status. So if you're thinking that you're passing the exam and then coming to work, unfortunately, that's not possible. So do your homework in that regard as well.
Yeah, okay. Thank you so much, Dr. Samina. I think I have all those questions we have answered. So we are now at the end of our session. And I would like to say good luck to all my IMGs who are writing their exam or planning to write their exam. Thanks everyone for your commitment and taking your valuable time from your busy schedules. I would like to thank for all my panelists who had done a great job and very well elaborately they have told how to write exam. And this is actually a very good resource and very good help for the IMGs, which when we were writing exam, we did not have such kind of channels and no one was there to help us in such a way. So you guys are lucky. So good luck, everyone.